So I'm Pauline Bianchi. I am the Senior Vice President of Research and Programs at the Foundation and have been with the Foundation about a year and a half, and just want to say how excited I am to see you all. This is our first Nurse and Allied Health meeting, and we started actually in a room that would accommodate 50 people. And I don't know how many weeks it took, but we sold out pretty quickly. We're expecting, I'm sure some other people will kind of trickle in, but I think over 80 people. So I'm super excited, and I'm going to say this right now that, you know, in all my travels, I've been out to probably 50 plus of the 68 sites. The nurses and allied health professionals are my favorite. So I am a nurse by background many moons ago, but, truly appreciate what you all do. And, I think it's one of the critical pieces to be successful as a care center network site. So I want to ask a couple questions. So who here is part of a care center network site? Okay, so most, great. Okay. Then I'm going to ask too, who are nurses? Okay. Who are nurse practitioners? Great. I never know if you're a nurse or do you lose the nurse title once you become an NP? You're always a nurse? Like a Marine, once a nurse, always a nurse? Okay, yeah. And then how about respiratory therapist? Oh, great. Okay. Clinical coordinators. Wow, what a great mix. Okay, any physicians? Okay, good. We were in a major leave, so yeah, okay, yeah. So that is great. Again, I'm so happy. I wrote down some notes. I want to make sure that I remember everything. So I'm really pleased with the faculty that we have. I think experts in all the areas that they're speaking in. And, again, I've been really privileged to be able to work with them over the last year and a half since I joined the foundation. So hopefully it'll be really interactive. We have a lot of material to cover, lots of great cases, and, please ask questions. Our goal is to have time at the end of each presenter for questions. So then kind of last thing is, let's see, is this anyone's first summit? Oh, wow, that's great. So this is my fifth. This is the first time I've been on this side of it, and I'm going to tell you it's a lot easier over there. So as Lewis and I were up last night looking at slides, I think at midnight, but really, really happy. Hopefully you all enjoyed this meeting as much as I have, and you'll continue to come. So just a couple housekeeping issues. You all have, obviously you have the red badges for today, and then the other badges you do need to have at all times. This is a highly sought after meeting, so if you don't have a badge, they're not going to let you into any of the sessions. Then let's see, just also, we do have coffee and things in the back. Help yourself. There's water outside. And then we will have, I think, a break later this morning and have, I think, some snacks with that, so hopefully. And then we're going to have a lunch. And our goal is to kind of sit down and talk, very open about what can we do as an organization, as a Nurse and Allied Health Network. So that's another question. Who here is involved in the Nurse and Allied Health Network? Okay, so we're going to get the rest of you on that, and put you to work, sadly. So that's what happens when you come. Let's see, just to let you know, too, there is another group in the hotel. So if it seems really kind of chaotic and busy, they're supposed to leave later today. So hopefully it'll just be more of our group kind of for the next couple of days. So without further ado, I'm going to introduce Carolyn and Jennifer, both from the University of Washington, and they are probably at one of the premier and busiest centers in the country, and I've been up to visit them, and they're kind of crazy with how much activity goes on in there. I think they both came from an ICU background, which I think is a very common path that you see people that have been in the ICU and somehow end up in ILD. I guess if you can handle that chaos and craziness in the ICU, you make a good ILD nurse or allied health member. So again, they have, since 2000, I think they've been doing this, so a lot of experience. They're going to kind of start at the very beginning, just talking about kind of the overview of all the alphabet soup of ILD. So I'm going to welcome you guys up.
Hi, Well, we're really honored and excited to be here at the first Nurse and Allied Health meeting. We're really thankful to the Pulmonary Fibrosis Foundation for putting this together, and the nurses on the board who said the nurses and allied health, the RTs, all of the ancillary staff that work with us are the people that are doing the details, taking care. We need their expertise and everything there, so we're really thankful to have that and all the tips and support we've gotten. So we encourage the rest of you to kind of get on the platform and go join us. And Jennifer and I, as she said, have similar professional backgrounds, so we've been co-coordinators for 20 years. At this point, about 9 times out of 10, we'll answer a question the same way. So if you want to test us later and separate us and try that, that's fine. So we've been challenged today with a big topic. So obviously we'll be scraping the surface. In the overview of ILD, we're charged with providing a definition, how we recognize ILD, and going along with that is symptoms and presentation, outcomes, and the major ILD categories. Other speakers will be fleshing it out, so we'll touch on things and they're going to provide the depth.
So I just want to echo what Carolyn said. It's been fantastic to see how far the foundation has come in the contributions for the patients with ILD. I'm happy to be here. So the ILDs are a large group of disorders that affect the interstitium of the lung, that space and tissue that surround the alveoli and capillary. The lace-like tissue is made up of connective tissue, and it provides the structural and biochemical support to the alveoli. In ILD, this tissue becomes thick and stiff due to scarring and inflammation is often diffuse throughout both lungs. So the interstitial connective tissue consists of fluid and cells scattered throughout an extracellular matrix. The cells include fibroblasts that produce collagen, the fiber of the matrix, and cells with immune functions such as macrophages and lymphocytes. Normally the interstitium is so thin it cannot be seen on a CT scan, easily allows the passage of the capillaries through the tissue, providing the final pathway for exchange of carbon dioxide and oxygen. So because the principal cell types involved in immunologic defense are found within connective tissue, it is the stage for inflammation. The fibroblasts are essential for normal development and repair. They're quiescent in adults, but can retain the ability to be reactivated and multiply when necessary during repair after an injury. So the problem in ILD is, for some reason, perhaps in a genetically predisposed individual, the fibroblasts are activated and just don't turn off. Excessive collagen is produced, forming scar tissue, and in addition, the immunologic function cells become activated, causing inflammation. So scar tissue, the collagen deposited by fibroblasts during repair, and inflammation prevent or make the exchange of oxygen and carbon dioxide more difficult. As a result of the ongoing fibroblast proliferation and continued scar formation, diffusion of oxygen is reduced, causing low oxygen levels, which in turn leads to the primary symptoms that patients present with: dyspnea on exertion, cough, and fatigue. So in ILD, this abnormal healing response allows for continued collagen production and scar formation, causing thickening of the extracellular matrix, and fibrosis as the disease progresses, further decreasing lung function. So the course is unpredictable in people. It depends on the type of ILD, how soon it was diagnosed, response to treatment, how extensive the fibrosis has become, makes for a varied prognosis. So some ILDs present acutely, some are chronic and irreversible, and some are short-lived. But as the disease progresses, you may see a stair-step progression. You may be a period of stability and then a worsening due to maybe an infection or exacerbation, then hopefully response to treatment and leveling out again, but it's just unpredictable. The progression of symptoms vary from person to person. You know, basically the symptoms worsen as the disease progresses, and I'm sure we've all seen this. You know, unfortunately, you know, they have dyspnea and exertion, and then eventually perhaps at rest or with very little exertion. Many will require supplemental oxygen as the disease progresses, and Susan will get into this more in her presentation. But you know, it's not uncommon to see high levels of supplemental oxygen need for little activity, 10, 12, 15 liters. And then the cough is just usually the dry hacking cough, and it's often the symptom that will bring patients in to see their doctor, as it's so annoying.
So we learn through the experiences of our patients. So we thought it would be more interesting, at least to us, and we hope to you. But all that mattered was us, actually, because we put it together. So as we discuss the categories, to share some ILD disease types that we see most often through the journeys of our patients. Usually in academics, these are called case studies, but we're going to call them our patient stories, because everyone has a story to tell. These are short, but bring in some of the key points regarding these diseases and the people who fight them.
So the ILDs can be divided between those associated with a known cause and those that are idiopathic. Treatment choices and prognosis vary among the different causes, so the correct diagnosis is important. The ILDs can be grouped based on cause, association with other diseases, or pathology. Here we've divided as follows. The pneumoconiosis, or occupational-related interstitial lung diseases, such as asbestosis. I recently heard a story on NPR regarding an uptick in silicosis among young Hispanic men who worked as fabricators and engineered stone for countertops. So the countertops, I guess, are comprised of over 90% silica. So the worry, it's caught the eye of the CDC, the worry is that with the popularity of these countertops over the last decade, there's potentially a large number of affected workers. And then the treatment-related, certain medications, radiation, chemotherapy are associated with ILD. Ironically, methotrexate is often used to treat sarcoid and other autoimmune disorders. And then the connective tissue-associated ILDs, such as rheumatoid arthritis. ILDs is the primary lung manifestation in rheumatoid arthritis. Scleroderma, which we will highlight in a patient story. And then the inflammatory myopathies, such as polymyositis, dermatomyositis, were characterized by muscle weakness. ILD manifestation can occur before or after the myositis diagnosis. And then Sjogren's, characterized by dry eyes and dry mouth. ILD symptoms typically occur several years after the Sjogren's diagnosis. And then the immunologic-related ILDs, such as hypersensitivity pneumonitis, sarcoid, chronic beryllium, we'll highlight in a couple of patient stories. And then, of course, the idiopathic interstitial pneumonias, where idiopathic pulmonary fibrosis is the most common, in fact, the most common ILD overall.
So scleroderma, or systemic sclerosis, is a systemic connective tissue disease, so it can affect multiple organs. It most often appears first as skin changes, so then patients are commonly referred to dermatologists or rheumatologists. It usually occurs in women in their 30s. It causes thickening and hardening of the skin and other body systems. Interstitial lung disease is one of the leading causes of mortality in patients with systemic sclerosis. So Rod was in his mid-30s when he was diagnosed with scleroderma. He was a physical therapist who actually noted his own skin changes and Raynaud's. Upon history and exam, it was noted that he complained of swallowing difficulty and reflux. He was managed for these symptoms, but at 45 he developed dyspnea on exertion and a dry cough, so he was referred to our center. His PFT showed restriction with a reduced diffusing capacity, and his CAT scan already showed ground glass opacities and some fibrotic changes. As we do for all of our patients, we referred Rod for a 24-hour pH with manometry to check throat pressures and motility, and an esophagram. These showed reflux and no esophageal motility. This is unfortunately common in scleroderma due to thickening of the throat. His echocardiogram showed mild pulmonary hypertension, which often occurs with ILD. He was treated with mycophenolate and started on sildenafil by his rheumatologist for digital ulcers, which had the additional advantage of treating his pulmonary hypertension. We followed him every 4 to 6 months concurrently in the rheumatology ILD clinic. 4 years later, his PFTs dropped significantly, and he started experiencing nausea on the medications that he'd been on. And most unfortunately, he started to have spontaneous pneumothoraxes. Also concerning was that he began to lose a significant amount of weight, citing his nausea and difficulty with swallowing, causing fear of choking. In another year, he lost 50 pounds, so he had a PEG tube inserted. He needed 10 liters of oxygen, and his PFTs had dropped even more precipitously. He was referred to lung transplant, but he was turned down due to the lack of peristalsis in his esophagus. Many transplant centers have this as an exclusion criteria due to fear of chronic aspiration, damaging the new lungs, and causing continuous post-transplant issues. Some transplant centers, however, do transplant those with scleroderma or low or no throat motility or esophageal motility, often inserting a PEG tube and making them MPO, sometimes making them commit to never taking food by mouth again. Rod was transplanted at UCSF in 2015, and he's still alive.
So the immunologic-associated ILDs include hypersensitivity pneumonitis, also called bird fancier's disease, farmer lung, and hot tub lung, among others, is an immune system disorder where an exaggerated response occurs in some people after inhaling mold spores, bacteria, mycobacteria, animal droppings, and which then causes interstitial inflammation. With high levels of inflammation, the immune cells begin to collect in the interstitium, hampering gas exchange. Tends to be steroid responsive, and often removing or avoiding the exposure will reverse or resolve symptoms. If untreated, the inflammation can cause irreversible scarring. And sarcoid is an inflammatory disease that can affect multiple organs, primarily the lung and lymph glands, but also the heart, skin, and eyes. The cause is unknown, but there's an overactive immune response of ongoing granuloma formation in the affected organ. The abnormal nodules or granulomas, made up mostly of lymphocytes, continually form, causing inflammation, and the symptoms really depend on the organ involved. Carolyn will present the hypersensitivity story.
A good history can often elicit an exposure indicating hypersensitivity pneumonitis, but sometimes it takes some detective work by sending an industrial hygienist out to the home or workplace, or having people do their own home swabs once they're educated on where and how to do it. Hillary was referred to as complaining of dyspnea on exertion. Her primary doctor had already done a CAT scan as they were ruling out a pulmonary embolus after a trip, and that showed bilateral ground glass opacities. Her initial diffusing capacity was quite low, so she obviously had a problem with oxygen carrying out to her body. Her basic history was not illuminating. An expanded history, however, and CAT scan pointed toward the hypersensitivity diagnosis. She had pet pigeons for more than 4 years, and she kept them in the house, though birds in close proximity outside can also cause an exposure. Hypersensitivity panels can be sent for avian antigen and mold antigen, but that only tells if there's been an exposure, not necessarily if someone is currently being exposed. The offended antigen is identified only about 50% of the time. Labs showed high mold antigen levels along with the evident avian exposure. And home studies showed poor housekeeping and evident water damage and mold. HP was high on the diagnostic differential, but one serology was positive for anti-CCP, but no other rheumatology labs were positive. Hillary wanted a lung biopsy to make sure, as she was very attached to her birds. The pigeon exposure is significant, even though she hadn't developed symptoms for 4 years. It's possible she may have been manifesting a subclinical, subacute hypersensitive pneumonitis for quite some time. An apparent viral infection following her trip to Arkansas may have surfaced the inner lung disease abnormality. Some people are very attached to their birds, so telling them they need to remove them is upsetting. One of our doctors started saying rehome instead of get rid of them, which seems to be taken a lot better. It's also interesting how some areas of obvious mold are overlooked. Usually, however, they're hidden, such as mold under the carpets only found when they pull them up, mold under the sleep number bed, or birds nesting over the patio. Hillary was started on prednisone, and she had the expected response and remained on a low dose. Her FVC went up to 99%, and her DLCO up to 76%. She also had improved symptoms and an improved CT. But then there was this twist at a visit. We often wonder why one person in a household gets HP and not anyone else. Well, we don't know that answer. Maybe it's a genetic predisposition. In this case, her partner did start to exhibit pulmonary issues. However, this was the most unexpected outcome, and we took this directly out of a transcript. Those of you who know us will know whose transcript. The question is, as far as the potential infestations of the antigens in and on his impressively coiled dreadlock long hair, growth over 25 years, is intriguing, and although he's been washing his hair regularly, he does not unfold the coiled dreadlock lengthy hair, and it's conceivable that his hair may have manifested the antigen exposure. and would be of interest to culture a sample of the hair for environmental factors. This could potentially be pursued. So, Hillary's husband did clip a chunk out of his dreadlocks, and we sent it for culture. And it did culture out a mold type known to cause HP. And guess who had to call him to tell him he had to cut his dreads? Yes, of course it was us, the nurses. The happy ending is that both improved with prednisone, and their PFTs normalized to the point that they were able to stop coming to see us. They did clean up their environment, too. So sarcoidosis is most often diagnosed incidentally after someone's had a chest x-ray for another purpose and it shows hyaluradenopathy. It's also sometimes misdiagnosed as lymphoma. While it most often occurs in the lungs or eyes, it can occur in any organ. Possibly the most serious manifestation is when it occurs in the heart, as this can cause arrhythmias that can be the first sign and can be fatal. George was an Alaskan who had a surveying business, so he worked in remote areas. He was first referred to cardiology for weakness and shortness of breath with exertion after his local doctor found atrioventricular block on a cardiac stress test. Specialty services are not very available in Alaska, so he flew to UW, as many Alaskans do, for pacemaker insertion. Since our cardiologists worked closely with us, they suspected cardiac sarcoidosis and sent him to our center for evaluation. Our workup with those with suspected cardiac sarcoidosis includes a cardiac MRI, cardiac PET, PFT, and CT. We often refer them to our eye center to be seen by an expert ophthalmologist. We sent lab panels to rule out other causes of ILD, and with him we got a 24-hour urine for calcium since his level was elevated and sarcoidosis can manifest as hypercalcemia. Our doctors were comfortable with a diagnosis of sarcoidosis at this point. But George wanted conclusive proof. Alaskans are like that. So he had a lymph node biopsy, as he was one of the easier biopsies to do. His diagnosis was confirmed, and it was recommended that he have an ICD plus pacemaker inserted. Prednisone was started, which is often a first-line drug that we use, and then methotrexate started later, and prednisone weaned to mitigate the long-term steroid effects. Months later, George did go into V-fibroresque in a remote area of Alaska, and his ICD saved his life. He was re-imaged showing more activity. The cardiac PET or gallium-thallium nuclear medicine exams show activity, while cardiac MRIs just show damage that's already occurred. So cardiac MRIs are diagnostic, but nuclear medicine scans are better for following activity and suppression of activity ongoing. Fortunately, he's now been stable on medications, and his ICD hasn't fired in 8 years.
One more.
I forgot to change the slide. Thanks. Couldn't figure out what I did wrong at first.
So the idiopathic interstitial pneumonias are interstitial lung disease without an identifiable cause. They are separated into subtypes based on differences in histologic patterns, radiographic features, and clinical features, but all patients present with dyspnea. All are characterized by varying degrees of inflammation and fibrosis, and treatment and prognosis vary depending on the subtype and the amount of fibrosis. Complete information on the classification of the IIPs can be found in the ATS-ERS guidelines. We'll just discuss the clinical presentation. The most common is idiopathic pulmonary fibrosis, which we'll discuss with our patient story. Nonspecific interstitial pneumonia is seen more frequently in women in the 40 to 60 age range, and the symptoms may present as a subacute or chronic. Desquamative interstitial pneumonia is more frequently seen in men over 50 who smoke, can present subacutely to chronic as well. And smoking cessation results in clinical improvement in an estimated 75% of patients. Lymphocytic interstitial pneumonia is very rare, mostly seen in women of any age, presents chronically. Respiratory bronchiolitis, ILD, seen slightly more in men aged 30 to 50 who smoke, can present subacutely, weeks to months. Cryptogenic organizing pneumonia affects men and women equally, usually in their 40s to 50s. Cigarette smoking does not seem to be a risk factor, and about half of patients recall having an illness that resembled a community-acquired pneumonia. So Carolyn will present the IPF story.
So IPF is the ILD diagnosis that we seem to discuss the most. IPF is progressive and ultimately terminal. It most often occurs in men in their 60s. Until 2014, there were no treatments and there is no cure. People can have lung transplants if they're eligible. Nothing currently available reverses fibrotic lung. medications are approved that decrease the expected rate of decline. So this is Don's story. Don was a middle school teacher, and he was 54 years old when he first presented to our center. Previously, he saw a local pulmonologist for an abnormal chest x-ray that was discovered during a hospitalization for hyperglycemia. His local pulmonologist did a high-res CT showing the UIP pattern, and the doctor ordered a lung biopsy to confirm due to his age. He was tested for autoimmune markers, but serology was negative. Don also had a home that seemed to be one biohazard after another. Water damage causing mold, birds roosting, and so on. That all turned out to be just a red herring, as he did do all the diagnostic criteria for IPF. Don was our patient much before OFEV and Esbriet were approved, so from treatment choices we had, he decided to treat his reflux and enroll in clinical trials. Don did everything right in terms of what we have to recommend to patients: clinical trials, pulmonary rehab, oxygen, support groups, medication. And when he deteriorated finally, despite all this, though he was clearly a survivor, as he had an atypical progression going over 14 years, when the approximate lifespan of pulmonary fibrosis after diagnosis is only 5, he opted to get a lung transplant listed, and he did get transplanted soon after. Unfortunately, things went wrong from the start, and after transplant, he had rejection and infection. And he died without leaving the hospital of an overwhelming infection. Fortunately, that's not typical. Don did everything we asked him to do and more, and he's a hero to us for volunteering for trials, mentoring others in support group, as are many of our patients. We'd like to quickly highlight this just to emphasize how far we've come in understanding these diseases in a relatively short period of time. My first job in ILD was a research coordinator for this study. I kept running it as I transitioned to sharing the ILD coordinator job with Jennifer. This study was the result of decades of work by those in the ILD community, doctors, nurses, patients, convincing those with promising medications that an IPF study could be successfully enrolled. It opened the door for more research and development of potential treatments. So even though it was negative, it was very important. The American Thoracic Society consensus statement on IPF, besides helping those who tried to diagnose this condition, also encouraged studies as it reassured again that IPF could be properly and reproducibly diagnosed. Since that time, it's been updated multiple times in conjunction with the European Respiratory Society, and these documents have advanced research tremendously and are a great resource. So 20 years later, this is now the result. Of course, increased advocacy from the emergence of a larger, more active Pulmonary Fibrosis Foundation, patients and families, and other advocacy groups have been instrumental. Increased clinical trials did result in medication approvals for IPF, as you know, and many other medications are now in trials for other forms of ILD and fibrotic lung disease associated with other diseases that cause ILD, such as Scleroderma, which had recently had OFEV approved for ILD scleroderma lung. This is just a short bright spot we wanted to highlight, just to tell you how far we've come in a short period of time once the ball started rolling. So we'll defer questions until you've heard the other speakers, since we're the shallow people and they're going to go into depth. Your questions might get answered. So anyway, we want to leave you with a view of the Pacific Northwest, and we hope you'll come and visit us sometime.